Excuse me if I had a big somebody shouted at me then that I'm being recorded. Give me a bit of a start. Yeah, welcome everybody. My name's Kay Darby. I'm the interim Chief Nursing Officer, or to the long title, not the shorthand, for the ICB, covering Caroline Trevithick while she's the CEO, Chief Exec. So thanks very much for coming to this grading workshop today. And unfortunately, I can't stay with you the whole day because I've got kind of a few diary clashes. But thanks very much for giving up your time for the event. And as most of you will know, this is the kind of last of 3 equality delivery system grading workshops that we've had through sort of 2023-24. So if you're probably aware, there's been 2 previous workshops, and some of you likely will have attended those. Thank you. So I understand we had the virtual wards and the tuberculosis service back in November. So this is the sort of 3rd, and is it the final one for this financial year? So as you know, today's session's focused on maternity services in relation to diabetes pathways. And the clinical lead, Elena, is it Eleanor or Elena? Eleanor? I'll give you a nice kind of
Helena, I'm not fussed.
I gave you a continental slant to your name, Eleanor. We're presenting the evidence from the maternity services on how the services deliver equalities for people who live locally and wider users of the service. So as a lot of you will know, that tackling inequalities and kind of providing equity of access is a key priority for the integrated care system. And that's why we want to hear your views on how we think we're doing against the kind of pledge today. So we'd like to understand how you think we're performing. I've been, kind of heard the evidence that's going to be presented to you today. And so I do hope that people do feel that they can give us quite open, comfortable enough to give sort of open and honest feedback, because we'll only kind of learn from understanding sort of what your views are, or kind of what your suggestions are for improvement based on your knowledge and your kind of personal experiences, or your kind of experiences from being part of the community. So it is important that we, for our performance in providing inclusive and equitable healthcare, that we do kind of get a range of views across Leicester, Leicestershire and Rutland, so particularly from people who represent demographic of the population as well as the patient participation groups, because you clearly are people who are committed to giving, spending a significant amount of your time to kind of giving us input into how we run the services. But particularly want to hear from people from kind of protected groups and people in across the wide range of kind of our communities. So once again, thank you for being here. And as I said previously, I hope you feel kind of comfortable enough to sort of fully engage during the session, and that you can be very openly share your views on where we're at and where we need to be in respect of kind of continuing to close kind of health inequality gaps. So Marion is going to do a short presentation on EDS before Elena will come in to do her presentation. So thanks very much, everyone.
Thank you, Kay.
Thank you.
No, thank you. So I will go through just a very brief presentation on what the EDS is, just to sort of set things in context before Eleanor presents the evidence. Do you want to move to the next slide, Pooja, please? Yeah, thank you. So the EDS stands for Equality Delivery System. It's an evidence-based equality performance improvement framework, which helps us really to assess where we are and where we need to be and what we need to do to then close that gap. So it's kind of, gap analysis and improvement framework for equalities. It's mandated, but we're doing it because we want to get the best outcome, not just for our workforce, but also our patients. It focuses on improving health inequalities, closing the gaps, and also workforce inequalities. It's also designed to help us to comply with a number of statutory instruments, such as the Equality Act 2010 and the Health and Social Care Act 2012, which obviously asks us to address inequalities, whether that be in the workforce or, health. And if we cast our mind back to a few years ago at the outbreak of the pandemic, the COVID-19 pandemic, that shone a bright light on the inequalities that existed even prior to the pandemic. And because we're saying, they're health inequalities, they're actually things that can be tackled, whether to improve access or to improve experience of care or to improve outcomes or even to improve prevention, to prevent people from falling ill in the first place. Next slide. I want to avoid saying that. So the EDS, or the Equality Delivery System, is designed to be applied to protected groups or protected characteristics groups as defined by the Equality Act. There are 9 of them, and all of us here on this call, we have maybe 5, maybe 7 out of these 9 protected characteristics. So we all have an age. Some of us have disability, some of us don't. We all have gender or sex. Some of us have people of faith, some of us are not. But the equality delivery system is designed to be applied to the protected groups. And in addition to that, we have wider equality groups, armed forces community, for example, the transient population, the homeless people, maybe rough sleepers, people who don't have maybe a fixed abode, are traveling community, and so on and so forth. Next slide, please, Pooja. So there are 3 parts to the quality delivery system. We are focusing on domain 1. So as you can see on the screen, those are the 3 domains, and each of the domains have some outcomes attached to them. Today, we're focusing on domain 1, which is designed for services commissioned for patients. And there are 4 parts. And the evidence that Eleanor will be presenting today will be against outcomes 1A, 1B, 1C, and 1D. Next slide, please, Pooja. In terms of the process, what we've been doing over the past few months, for domain 1, we are required to select 3 clinical services. And as Kay mentioned earlier, we've already had a grading workshop for each of the 2 other services, virtual ward services and tuberculosis services, back in November. And this is the last of the 3 clinical services that we're applying domain 1 to the CDS cycle. And the key components really is engagement, evidence, insights, assessment. Where are we? What can we do to close the gap? So we'll be looking to you today as key stakeholders, to feel comfortable to share your open and honest views as to whether you experience, or if you're a member of a patient participation group, what do you think, where do you think the gaps are, where are the improvement areas, and what can we do maybe to close some of those gaps. And I will just use this opportunity to say, for some of us on this call, you might actually be from the maternity services, specific maybe perinatal diabetes. We want the evidence to be objectively and independently assessed or graded. So we'll ask you not to grade. It will just be for other colleagues and obviously our community, stakeholders, our patient representation groups, and other maybe members of the VCSC Alliance across Leicester, Leicestershire, and Rutland, who will be asking to grade the evidence that Eleanor will be presenting to us today. Domain 1, because it focuses on tackling health inequalities and improving population health, we work with our clinicians, and for this clinical pathway, we've been working with Helena, who's been, gathering evidence with other colleagues, and she will be presenting evidence against the 4 outcomes for domain 1 that I referenced earlier. She's obviously, will be using a slide deck to showcase the evidence. We have this workshop, which we have to publish once we've taken it through a governance process. And then whatever gaps or improvement areas that have been identified, the clinical pathways will be required to deliver on those improvements and reports on progress in the coming months, in the coming years. Next slide, please, Pooja. So your role today, really tell us, what do you think, how do you think we're doing with regards to outcomes 1A, 1B, 1C, and 1D, based on the evidence that Eleanor will be presented. If you want to give us some feedback, there'll be an opportunity to do so. We'll be using a grading form on Microsoft Form. So there's a link and there will be a QR code that will be popped in the chats as we go through each of those outcome areas. And if you want to suggest any improvements as well, feel free to do so as well. Next slide, please. So the first of the four domain 1 outcome, patients or service users have the required levels of access to the service. The evidence that's been gathered by the pathway will either show that there's no or little activity that is taking place in regards to patients having the required levels of access to maternity services in relation to diabetes. In that case, that will be showing underdeveloped activity, or it will be showing minimal, minimal basic activities or developing activities taking place, or it will be showing that it required some level of activity. So it's achieving or excelling, in which case it exceeds the requirements. So when we ask you to score using the Microsoft Office forms, you'll be scoring either 0, 1, 2, 3, based on how you assess the evidence that's been presented to be. Is it showing underdeveloped activity, developing activity, achieving activity, or excelling activity? An example of evidence that we'll be expecting Eleanor to present have also been tabulated on this table. So as she goes through the evidence for 1A, we'll pause and we'll put this slide on the screen for you to have it to hand to be able to help you with grading. Where do you think the service is at with regards to outcome 1A? Do patients have the required level of access to the maternity services in relation to diabetes? Next slide, please. The same goes for outcome 1B. Individual patients or service users' health needs are met. So the evidence that will be presented against this outcome will either be showing underdeveloped activity, developing activity, achieving activity, or excelling activity. So you can use the example of evidence that is on this table to judge, but there might be more evidence, obviously, that will be presented that will help you to gauge how to score. And the scoring range is between 0 and 3. Next slide, please, Pooja. The same for 1C. When patients or service users use the maternity services in relation to diabetes, they're free from harm. So based on the evidence also that Eleanor will be presenting, you'll be grading. And the same applies to outcome 1D as well. Patients or service users report positive experiences of the service. You'll be using this as a guide to help you with grading the evidence that will be presented. So I will pause here and call on Eleanor. So if you stop sharing for now, Pooja, to start presenting evidence against domain 1. She will pause after 1A and we'll do the same all through till we get to 1D. Over to you, Eleanor.
Morning, everybody. So I am very much a clinician. I'm a consultant obstetrician and I'm the lead for the antenatal diabetes service. We're a big service and we are very multidisciplinary. So we have obstetricians, diabetologists, diabetic specialist midwives, specialist nurse in diabetes, dietitians. So it's a big team, and I hope over the course of the morning, I give you a flavour of what our service is like, but it's a very specific service, so please feel free to ask me any questions for clarification. Great. So our maternity service cares for two very specific groups of women with diabetes. The first group is women who have diabetes before pregnancy. So this may be women with type 1 diabetes, some of whom will have been diagnosed in childhood, and also a growing number of women with type 2 diabetes. And this is growing for us locally and also nationally. And I'll talk to you a bit about the difference between the groups. Now, the other group, which for us in Leicester is by far our biggest group, is women who develop gestational diabetes during pregnancy. And again, this is increasing. For us in Leicester, 10% of all our pregnant population will be attending our service. So 10% of women will have some form of diabetes in pregnancy. The national average is 5%, and this reflects our local population, the fact that we have a much higher prevalence. So if we look at the total numbers, we can see that the women with type 1 diabetes are the smallest group, and their numbers are quite stable. The group with type 2 has been increasing, and you can see we've already got 41 women who are going to deliver this year in the service. But by far the biggest group is the group with gestational diabetes, and that's called GDM, and I'll probably refer to GDM quite a bit, but they're the women who have new diabetes diagnosed during pregnancy. And the way we diagnose this is by screening eligible women with something called a glucose tolerance test, and this is organised by community midwives. The reason this is so important is that women who have diabetes in pregnancy have a higher risk of complications. Now, this data is specifically talking about the women who have diabetes before pregnancy, known as type 1 and type 2 diabetes. And if we look at the bottom, the national UK rate of stillbirth is 3.5 per 1,000 births. But if you compare that to the women with type 1 and type 2 diabetes, you can see it's much higher. And the same with the neonatal death rate. And for this reason, there is a real focus on improving care for women with diabetes in pregnancy. And there's recently been a national document called Saving Babies' Lives. Version 3 was published last year, and for the first time there was a new element which is specifically aimed at improving care for women with type 1 and type 2 diabetes, and this has to be fully implemented by March. So this is another project which has been keeping us very busy running alongside that. Now, this is data we provide every year. I'll just talk you through this data, and what I'm trying to show you in this data is what our local population looks like, and also some of the differences between the women with type 1 and type 2 diabetes. So can you see my mouse? Yeah, great. So this data is for 2020 and 2022. For us, that's a cohort of 255 women. And the women are divided into those with type 1 diabetes. So that is when people have a lifelong requirement of insulin. It's an autoimmune phenomenon that often happens in childhood or in adolescence. Type 2 diabetes is different. That is diagnosed later on and can be linked with ethnicity. There are certain ethnicities that are at higher risk, and that is represented in our local population. Increasing age increases the risk, and increasing body mass index. So if I just talk you through our population, we can see that our women in grey are the women with type 2 diabetes, and they are overall heavier than the women with type 1 diabetes. They are also older, and they have had diabetes for a much shorter time. So the women with type 1 diabetes have had it on average for 13 years, whereas the women with type 2 diabetes have had it on average for 4 years. Now, for us locally, we can see The majority of our women, 75% of our women with type 1 diabetes are white, and a smaller population Asian, Black and mixed. Whereas for our women with type 2 diabetes, the majority, just nearly 60%, are Asian, with a lower percentage being white. If we look at our deprivation data, we also see that our women with type 2 diabetes are more likely to be in the 4th and 5th quintiles. They're also more likely to be taking harmful medications. And when we look at how well prepared they are for pregnancy, this is a real problem in both groups. The reason this is important is when this is a slide provided by Tina, who's my colleague and available today, and part of her job is she's a clinical advisor to Embrace, which is an organisation which investigates maternal and perinatal death. So we can see our population of women with type 1 diabetes are mainly here. Whereas if we look at our women with type 2 diabetes, they're mainly in this population. So they have a much higher rate of stillbirth. Now, I just want to give you some idea of the challenge of looking after diabetes for women in pregnancy. It's unlike any other time of their lives. And this is because the hormones of pregnancy change the physiology so much. So if we look at the amount of insulin somebody needs to control their blood glucose level, we can see that around conception, people become quite sensitive to insulin. But from 20 weeks of pregnancy onwards, the requirement for insulin may increase up to 3-fold the normal requirement. Now, for women who have no form of diabetes, this will just be silently met by their pancreas gland. But for women with diabetes, this means that they're going to need escalation in their dosage very frequently during pregnancy. So it's a very intense period of management, and they need a lot of support to make these changes, because we're also aiming to obtain incredibly tight blood glucose control. So we want women to have their blood glucose between 3.5 to 7.8, 70% of the time. And it's really difficult to articulate just how challenging this is. Now, looking at us, so what I would say is I am presenting very specific data. Every pregnant woman in Leicester in LLR actually has access to our clinic. What I'm looking at is these high-risk women with pre-pregnancy diabetes. And our goal is that we see these women by 10 weeks. And this is the data we submit to the National Pregnancy and Diabetes Audit. So this is also a benchmarking. So if we look at our past data that I presented, for our women with type 1 diabetes, we are seeing 65% of them by 10 weeks, compared to an average in England of 79.5. But our women with type 2 diabetes, and they're the ones who I've highlighted are at highest risk of poor pregnancy outcome, we're only seeing 33% of them by 10 weeks, compared to an average of 59%. Now, looking at last year initial data, we are improving this. And what I'd say is that because the women are so different, their entries to our service are also very different. So for the women with type 1 diabetes, they've had diabetes for much longer. So they've had very frequent contacts with healthcare professionals where the conversation of planning pregnancy has taken place. And also they've had the opportunity to say, let us know as soon as you're pregnant. They have access to diabetic specialist nurses, hotlines. Hopefully they're in one of our preconception services. So they know how to contact us. And as you can see, we're seeing them much earlier. We have the facility to see them literally as soon as they're pregnant. In the last 2 weeks, I can think of 2 women with type 1 diabetes, one who we've seen at 4 weeks and one at 5 weeks of pregnancy. So I think this is something we're achieving well on. Our problem is the women with type 2 diabetes they've had diabetes for much less time. The average is 3 years. They're also likely to all be in primary care, and they're not receiving that extra input. We know from talking to women that not all of these are intended pregnancies, but also this group of women are not accessing contraceptive services as well. So it's a really complex picture. So the question that we've asked ourselves in our service about this is, are there any demographics that highlight women at risk? And certainly in our day-to-day experience, we know that some of these women may be coming new to the area. Some of these women are maybe coming new to the country. So are there differences that we can identify and target? So these are 2 pie charts showing the ethnicity of the women, and I've split them into the women that we see at less than 10 weeks and the women we see at over 10 weeks to see if there are any different characteristics. And as you can see, the ethnicity representation is fairly similar. So I went on to look about first languages, because this is data that we record. So if we look at the languages, the first languages spoken by the women, we can see that in the group that was less than 10 weeks, the majority were speaking English, but there were women who had other first languages. I think the thing that struck me about this is that the women that were presenting in less than 10 weeks maybe had languages where interpretation was a little bit more widely available. If we look at the group of women who presented after 10 weeks, there are many more languages here. And we know that this is a challenge for women. A lot of the information is only presented in English, or they may have not received all the education appropriate. So what are we going to do about this? Oh, just actually looking at the need for interpreter, that wasn't really any different between the groups. So it's difficult for us to identify a clear group to target. We have a quality improvement project ongoing called the Getting In Early project. And I think the thing that we feel, and the thing that I'm interested in people's views about today, is that we have 2 clinics running every single week. So the minute we find out a woman is pregnant who has type 1 or type 2 diabetes, we can see them within 7 days. The challenge we have is being notified of these women. And these are all around in the community. So we know currently in LLR, we have 900 women with type 2 diabetes, age less than 40, who aren't using any form of contraception available, any prescribed contraception. So this is a big cohort of women that potentially may want to become pregnant or may accidentally become pregnant. So we need much more education, much more work in primary care so that these women are flagged to us early. So the first thing we've done is we have developed a self-referral form for all women newly pregnant, which is going to be launched next week via the maternity website. We're just waiting for some further interpretation. Now, of the 10,000 women we have pregnant a year, only 1.5% of them have type 2 diabetes. So this is kind of needle in a haystack. But we've been really well supported in the fact that they've allowed us to ask a specific question where we're asking women, do they have diabetes and what form of diabetes? And this is going to give us an opportunity to identify these women really early so that we can get them into our system. And other areas that have implemented this have found it to be very successful. We also need to increase awareness amongst women with type 2 diabetes. And again, there's a big national project called T2 Day, which is funded by NHS England. And it's specifically aimed at men and women less than 40 with early onset type 2 diabetes. And for women, there's that each person is going to have a 30-minute consultation with their primary care provider. And for all women, they're going to be offered contraception or pre-pregnancy counselling and referral to a preconception service. So we're also hoping that this will really help. We've got a meeting planned with Birmingham because they are doing a lot better than us with a similar population. And we're also getting some further information about specific areas or postcodes. Are there specific practices that we could target and have conversations with? So I feel aware that these figures are not showing us to be highly performing, but I just want you to be aware that you're making a judgment of our maternity service, and there is a limited amount that we can do for the women before we know about them. And we are definitely trying to increase access for the women so they can refer directly. And I think we're achieving well at 78% for the women with type 1 diabetes. And I think also we've really identified an area of need and are acting on this for the women with type 2 diabetes. But I just want to reassure you of our commitment, because by far the largest number is the women with gestational diabetes. And I think an example of this is during the COVID pandemic, where the Royal College of Obstetricians and Gynecologists changed the screening criteria for gestational diabetes. And one of my colleagues, Di Todd, who's one of the specialist midwives, she did some work on this, and she identified that if we implemented the recommended new screening, we would not diagnose 45% of our women with gestational diabetes. And because we are a high prevalence area, we felt this was a real risk. So we liaised with our colleagues in the community, and actually our community midwives carried on doing the glucose tolerance test, the gold standard screening for gestational diabetes. So for us in LLR, we continued to identify all the women with gestational diabetes, and they carried on coming into our service. And this later was demonstrated that we'd done a good move, because every other maternity unit experienced fetal loss from women with undiagnosed gestational diabetes, and we didn't experience that in LLR. So I hope this highlights to you our commitment to our local population at making sure that we can identify this high-risk women and give them access to our service. Thank you.
Thank you, Helena. So I'm going to call on you now to grade, score, and rate the evidence against outcome 1A of the EDS. The evidence that Helena has presented, what are your views in terms of the level of activity it shows, patients having the required levels of access to the maternity services in relation to diabetes? So we will pop a link in the chat and a QR code that you can scan. And once you do the scoring, so using this criteria, which we'll leave on the screen, either it is 0, 1, 2, or 3, there's a free text box below that for you to comment or provide some feedback on gaps, on other views. And if you hold on there, don't click on next just yet. If you click on next, I will take you on to 1B, and we want to do that after Helena has presented the evidence against 1B. So we'll pause for a couple of minutes to allow you to either click on the link or scan the QR code to do the grading. So that is in the chat. So if you scroll back to the previous slide, yeah. So if you just leave this on the screen for stakeholders, colleagues to have it to hand to help them with grading the evidence. Does anybody have any questions as well? Any feedback, any comment that anybody wants to make? I saw there was a question in the chat earlier when you were presenting, Helena. Hannah asks, are you working with the EMMM board around referrals to your service? They're looking to improve awareness among GPs and GP staff, particularly around preconception.
Yeah, I was in a meeting about that yesterday, actually, and they were talking about, I think they'll really want to make contact with Hannah, because they were talking about how much they were struggling to engage with primary care, because I think the proposed conference is only 6 weeks away, and they've really struggled to engage. So that is a key area, and we were talking about, we were talking about that in depth yesterday, and they want to sort of use our quality improvement project throughout the other areas when we finish the results of that. But yeah, we're desperate to engage with GPs, and if Hannah can, I think if it's the same Hannah I'm thinking, Hannah is the GP who is the link between maternity and primary care. So we're desperate for her input and involvement in helping us with this. Thanks, Hannah.
I'm here, Helena, and I met with the East Midlands Maternal Network, Maternal Medicine Network this morning.
Right.
So yes, I am speaking with them and looking at how to improve engagement with primary care. I think there's just a real lack of understanding around how primary care operates, if I'm honest. And they, advertised a day-long conference on the maternal medicine service. GPs just aren't going to sign up for that. It's, when you look at the scope of work of a GP, it's one tiny part. So I think there's other and better ways of engaging GPs. And the other thing that would be really important for for your service is engaging with practice nurses, because they do the annual diabetes reviews in every practice. So, GPs often don't have that much involvement in diabetes management and don't see those patients that often. So I think it's practice nurses, and you'd access those via the practice managers forums in each locality.
Great, thank you.
I think the other thing is just making sure you've really got a presence at the Eden diabetes course, because most GP surgeries are sending clinicians on those courses, and they will be sort of the key contact in each GP surgery, and making sure that this service is really promoted as essential. And I did the Eden diabetes course last year, and I don't actually recall this service being mentioned. There was a lot of information. It may be that it was, but it certainly didn't stick in my conscience as something I need to, really need to kind of, raise awareness around across my practice team. So,
sorry, Hannah, when you say this service, which service do you
mean? The maternal diabetes service. So, I think just kind of every opportunity. It's a sort of understanding the contacts that GP surgeries have. Who the key people are and how you reach out to them, how you connect with them, really.
Do you think that there's a lack of understanding that women with diabetes are looked after in a specific clinic?
I would say definitely. And I think also just those opportunities to have conversations with women of childbearing age around, just, by the way, have you thought, are you aware of this service? Even get, producing posters for GP surgeries to put up. We have lots of information, a GP surgery waiting room, something like a QR code so women can self-refer is a really great idea. But how do you get that code to those women, having those posters up in community pharmacies, that sort of thing. The women that have existing diabetes will be collecting their prescriptions, won't they?
Yeah, this was discussed apparently increasingly online.
I would say, yeah, there's still a lot of, a lot of people will go into a community pharmacy at some point to sort their prescriptions out. So yeah, just some thoughts around it, really, because I know the maternal medicine service are really struggling to reach GPs or get any engagement, but I'm just not convinced they're going about it in the right way and don't really understand the day-to-day pressures of, like, GPs often will have between 50 and 100 patient contacts in a day, so squeezing it into kind of their scope, you've kind of got to fit around how GPs work, not expect them to come to an educational event. And I know that wasn't sort of what you're suggesting with the diabetic service, but yeah, the maternal medicine service, I think there wasn't really an understanding of what primary care is like. So yeah, I just wanted to sort of to raise that here really, because it would really make sense to promote the services together, wouldn't it? It's all about improving medical care for women in pregnancy and preconceptually.
And do you think, I don't know if you've been involved with the T2 day, the early onset for type 2, because I'm sort of hoping that that's going to really raise the, you know, the contraception or the preconception question. What are your views on that?
The T2 day?
It's an NHS England national programme for early onset. It's type 2 diabetes of the young or something. It's early onset type 2 diabetes. It's not specifically aimed at pregnancy at all, but it's going to be a funded 30-minute consultation for people who are less than 40 with type 2 diabetes, and the specific questions aimed at women about contraception or preconception.
I haven't been involved in that, but it sounds like a great opportunity to raise awareness, not just among women, but among the healthcare practitioners that are delivering that service.
Thank you, Hannah. And thanks, Helena, for a comprehensive discussion. I can see a couple more hands up, Bina and then Rabina.
Yeah, fantastic. Thank you very much. Helena, thank you for such a comprehensive presentation and really getting us thinking. And participants that have joined us today, you know, if you need longer to reflect, we are going to work through the evidence for all 4 outcomes as Mariam described. So if you need longer, we are actually going to leave this open for a bit. Hannah, thank you so much for your feedback. Do put your questions in the chat, colleagues. I'm just mindful that Fran's also put in a few questions, comments, Helena, in the chat. One which is around, do you have service user feedback or anything from MNVP regarding access, and would practice nurses feel confident on pregnancy counselling? So a couple of points there for you to pick up as well. Please do put your comments in the chat. Any questions you've got, raise your hand. Take as long as you need to help us with scoring this. Thank you very much.
And I don't know.
Thank you, Bina.
Hannah's suggestion about practice nurses, obviously that's an area that I need to get more information about, because I think I was probably assuming that they were seen more by GPs, but this is really important information. We have quadrupled our preconception capacity since December. And there is a specific clinic for women with type 2 diabetes. So I'm hoping that this big increase in capacity does lead to more women accessing that service.
Thank you. Rabina, your hand is up. And whilst they're waiting for Rabina, just to let everyone know, we'll leave the grading form and feedback, grading and feedback form open for a week, maybe till next week, Wednesday, so the 31st of January. So don't feel pressured. If you want more time, we will be downloading the recording and send it out ASAP. So if you want to listen to it back, you can do so and then do your scoring. And also for the benefit of those who have not been able to attend as well, to give as many people the opportunity, you know, to listen to the recording and also do their assessments. Rabina, are you there? Okay, so I can't hear her. So whether there's audio issues, which we had, you know, before the session starts, or maybe it's to do with network. So we will give you maybe a minute more, you know, to score, if you want to score now. And if you just maybe raise your virtual hand so I can just sort of gauge how many people, and then we can move on swiftly to outcome 1B. So if you raise your virtual hand once you've done it, but don't feel pressured. Like I said, we will leave the form open for a week. And the QR code, if anybody's joined, the QR code, the link is in the chat. Thank you, Fran. Can't see any other hands, so I don't know whether people are reading or whether people want to do that within the next 1 week.
Mariam, I'm conscious Fran wants to come in, and then there's Paul.
Okay, I've just seen their hands. Sorry, I wasn't. I wasn't even sure whether that was for a question or comment, or whether to say you've graded. So it's sort of Fran and then Paul.
Sorry, you asked me to put my hand up if I graded. So
Okay, yeah, that's what I wanted to know. So Paul, have you graded as well? Is that what the hand is for? I have a feeling that is the case. It worked well when we did it in November. So, but if you have any questions, any comment, use the chat as well, and we'll try and pick that up as we go along, so we can even come back to it. So I'm mindful it's now 10:52, and we'll move swiftly on to outcome 1B. So over to you, Eleanor.
This is addressing the are we meeting individuals, patients' healthcare needs? And for us in our day-to-day clinical experience, the most obvious need is the need for understanding the huge amount of complex information that the women are given in a population that's very varied. So when we look at the first language of our population of women with gestational diabetes, and these are not the women who've had before pregnancy, these are women who are newly diagnosed with diabetes during the pregnancy. We can see that 52% of them have English as their first language, and then there are a vast number of other languages spoken by our population. Now, when we look at interpretation, this is something that is very, very important to us, because when women are diagnosed with gestational diabetes, the first thing, I'll just get back to the previous slide, the first thing they have to do is they're invited to a education session to be educated about gestational diabetes, to be educated about the risks associated with it, to start doing finger prick blood glucose testing 4 times a day, to be told about the dietary requirements, carbohydrates, proteins, how they should be eating, how they can exercise and influence their blood glucose. And this is a huge amount of information. And being told that you have diabetes in pregnancy is quite a negative piece of information for most women, and they feel anxious, concerned about it. And then when they come to see us, we ask a lot of them. So it's very, very important that the women are supported and can understand it. So we have down here that 122 women were judged to be requiring an interpreter. I'd say in our experience, it's probably more than this. So we ask this question when they book with the community midwife, and they will be asked, do you need an interpreter? And women that may say no at that point, when it comes to the level of detail required for the education for gestational diabetes, they may actually need an interpreter. 67% of the women are these 5 languages: Gujarati, Hindi, Punjabi, Urdu, and Bengali. And we have 2 regular interpreters that attend our clinics. Nisha and Mamta feel like part of the team, even though they're not UHL employees. They speak these 5 languages between them. And they also offer a service where they try to maintain continuity. So once they've translated for one woman, they then attend her future appointments. They both are attending clinic, but they divide the patients between them so that they can offer continuity for the women. So if a woman doesn't have that language, then we'll use another face-to-face interpreter. That's our standard. But if not, we may need to use language line. And last year, there were 42 different languages spoken by the women in our service. So our need for interpreters is really big, and it's a real priority for us. We also have considerable diversity amongst the MDT. I've spoken a bit about the number of different healthcare professionals in this clinic, and they speak these languages to a level where they can conduct a consultation. And these are really valuable in the clinical setting, because we may have a woman who has been newly diagnosed with diabetes. We ask her to start all the glucose testing, and then she may require some treatments during pregnancy. And there are women that require to start insulin injections during pregnancy. So it's incredibly daunting for them. And we have a clinical aide that can speak Gujarati and Hindi, and I think she's a really high value individual for us, because she will support a lot of the women with their education. The other thing we are very mindful of is that people have very different diets, and our dietitians have expertise in a wide variety of cultures, so they aim to be giving dietary advice which is specific to the woman. We also, group education is a very established form of education in diabetes, and is shown to be better than individual education, because people feel more comfortable and they benefit from the wider discussion. And we do hold group education in different languages. I'd say our most common language is Gujarati. And again, I'm not suggesting that when people speak the same language, they eat the same food, but it does give some opportunities for wider advice, which is more specific to their culture. We also are mindful and respectful of religious beliefs, such as if women choose to fast during Ramadan, and how we can support that. And one of our big priorities is to ensure that there's equal access to technology. Now, we have been using a virtual platform for blood glucose monitoring for the women with gestational diabetes since 2019. And what this means is that when a woman does a finger prick test, her meter then Bluetooths to an app, so that remotely we can see all the blood glucose monitoring. We can also communicate with the women via this by sending messages. Now, initially, when it was introduced, we discussed how appropriate it was for women who couldn't speak English well to use this technology. And there's different screens within this app. So we record if people need interpreters. But what we've realized is that this app allows us to be much more responsive to women's needs. So we can easily identify women who aren't testing their blood glucose. We can also easily identify women who have blood glucose levels that are outside of the recommended target range. So we actually made the decision that this should be access to everybody, regardless of their language, because even though we may not be able to communicate with everybody over the app, it allows us to respond to the women who have the most need, either because they're not testing or high blood glucose. There's another app that's being created by one of my colleagues, Angie Deshani. This is it, the Janam app. And this is a specific pregnancy app for which women receive the activation code at the beginning of their pregnancy. You can see the different languages here, 5 languages in addition to English. And we've done a number of recordings for this, and these are videos and the information is presented in translated videos. So within this app, we have education about gestational diabetes, and we also have things like recaps on how to do capillary blood glucose testing, dietary education. So this is another form of access for our women. The other thing we've done is that there's an aspect of the postnatal journey for women with gestational diabetes. And women with gestational diabetes have a 50% chance of developing type 2 diabetes within 5 years of pregnancy. And the gold standard is that they have a postnatal test at 13 weeks after their baby's been born. It's a one-off blood test in primary care, and then referral to a diabetes prevention program. Now, we did a project a couple of years ago where we identified that only 44% of our women were actually having this test. So we communicated with primary care, and we said, because we felt we were giving the information, but we weren't providing primary care with the information in a way that was useful to them. So one of our trainees did a project saying, you know, how would you like the information? What's the best way? And the response was that they would like a notification in System 1. So this was quite a big additional task for us, because you can see we have more than 800 women. So we developed a pro forma, and what we do now is we communicate the diagnosis of gestational diabetes through System 1, and we request the postnatal test at 13 weeks. The other added benefit that we've really seen through this is that we can support repeat prescriptions, because our communications improved, and definitely the women who were struggling to obtain repeat prescriptions the most were the ones that didn't speak English. So this has been another real advantage in supporting this group of women. Now, we've improved, the audit was done early last year, so we're hoping it's even higher, but our rate went from 44% to 65%, and we're hoping it's still higher since. And actually, the trainee wrote up an abstract for the National Diabetes and Pregnancy Conference about this work, and it was one of 3 oral presentations. So you know, it's obvious that this is a shared problem, and people were keen to know how we'd address this. So the other thing is, all the women, even if they're managed in the virtual pathway with gestational diabetes, we see them all for a face-to-face review at 36 weeks. At this point, we talk about what's going to happen around the time of delivery. We discuss the importance of monitoring fetal movements, and we have information sheets for this in 37 languages. We also know that if women don't speak English, there's going to be a barrier for them picking up the phone and calling advice around the time of labour. So we discuss how they contact our maternity admissions unit, and also reassure them that we can use a telephone interpreter to help them share the information that they need to with us. We promote breastfeeding, and we educate them about their future risk of type 2 diabetes. So in addition to the first test, 13 weeks after having their baby, these are a group that need annual checks because of their high risk of developing type 2 diabetes. So we're now shifting to the other group of women, the smaller group, but the women who have had type 1 and type 2 diabetes before pregnancy. And the real inequity in this group is their access to technology. This is, again, something that's present throughout the country, but it's one of those things that's sort of a postcode lottery, access to the technology. In the last even 3 years, there's been such a rapid rise in the technology available. And we have, I'm sure, even if you're not interested in this area, even in general press, they're talking about the artificial pancreas and things like this. And the thing that we now know is that pregnancy is a real opportunity to level up. So 100% of our women with type 1 diabetes have access to something called continuous glucose monitor, which is a monitor that fits on the back of their arm. And that's the first step that's just had such an impact on blood glucose control. And it's been shown to reduce admissions for babies to the neonatal intensive care unit. Locally, we've gone far beyond this, because we have had the opportunity to have some real experts coming into our service. So in December, we have appointed a professor of diabetes in pregnancy, Claire Meek. This is a real big boost to our service, as she's a national expert with a huge background in research in this area. We also have developed a role of a diabetic specialist midwife who leads in technology. So we're offering a lot of support to these women. It was decided, there was a NICE guidance technology review released in December last year, saying that women with type 1 diabetes who were planning pregnancy, who were pregnant, should be offered the very latest technology, the hybrid closed loop pump, and that's what's commonly referred to as an artificial pancreas. So in December, it was green lighted, but we actually already have 22 women who are currently using or have used this technology in our service, which is about 50% of our population. We have monthly pump starts happening, and also with regards to breaking down barriers so women can access this technology. I just learned yesterday from my colleague who's the diabetic specialist midwife that leads that one of the pump companies is offering to support a smartphone for women for 1 to 2 years during pregnancy, because it's recognized that the cost of a smartphone is a real barrier for people. And the thing I'd say is that there is a real difference in the people using this technology. So for instance, we have had some women who were self-funding it before the funding was available, but it's at least £100 a month. So that is obviously not most of our population. And also, if we look at data from teenagers, a teenager who is white with type 1 diabetes is twice as likely to be using this technology as a black teenager with type 1 diabetes. So there is real inequity across the board, and we're definitely viewing pregnancy as an opportunity to really level up, and all women have access to it through our clinic. Thank you.
Thank you, Eleanor. I noticed a couple of questions from Fran in the chats whilst you were presenting.
Sorry, I was mainly chatting to Hannah about things.
Sorry, my headphones sort of cut out. The evidence that Helen has just presented obviously is against outcome 1B. So we'll pop the QR code and the link to the grading and feedback form in the chat once more, just in case anybody has left or rejoined, because sometimes then you lose the previous transcripts or posting in the chat. Any comments, any questions? I'm trying to check the chat. I can see Tina's hand is up.
Hi everybody, I'm Tina, one of the diabetes midwives that works in the team. I just wanted to sort of pick up on individual health needs of the women that we see. And I sort of believe that once they're in our service, because of the MDT team that we have, the women are signposted to whatever they need. So all women have a full review of their pregnancy to date at the point that we see them, whether that's as a newly diagnosed gestational or somebody with pre-existing diabetes. And that could mean that the health needs isn't just met through diabetes, but referral into hypertension or renal or cardiac, safeguarding, or any other thing else that they might need during their pregnancy journey. A lot of our women are from ethnic backgrounds where dealing with mental health is important, and women don't often talk about this. But actually, it's an all-encompassing service that women have got the signposted needs to go to, so we can deal with everybody. Not only are we just dealing with diabetes, but we're dealing with everything that is affecting that woman in her pregnancy. So I just feel that I wanted to stress that as well, because the team is big and the women do have access to that support once we know about them and once they're in our service.
Thank you, Tina. So the evidence, you know, again, that we're asking you to grade is, do individual patients, their individual health needs being met? And the evidence presented, does it show underdeveloped activity, developing activity, achieving activity, or excelling activity? If you click on the link on the QR code, because some of you have left and rejoined, so maybe network issues, you will have an opportunity to also use the free text box to ask maybe questions or comments, or suggest gaps and improvement actions that can be taken. So please make use of that opportunity. We will leave the form open for a week. So we'll close it on the 31st of January, so next week, Wednesday. We will also download the recording. So if you want to listen to that again to help you maybe grade them. Well, if you're grading now, please raise your virtual hands so that I can use that to gauge how many people have graded. And we can move on to the evidence against outcome 1C. I can see a hand. I don't know whether that's for grading or whether you have a question or a comment, Fran. Have you graded?
You keep asking me to raise my hand, so I do.
Okay, no, I'm just checking. I'm just checking whether or not it's for I've graded or I want to ask a question. And you know, please feel free, colleagues, to use the chat for questions, for comments as well. So you grade the ranges between 0 and 3, 0 being underdeveloped activities, what you think or believe the evidence that's been presented shows, or 1 for developing activity, 2 for achieving activity, 3 for excelling activity. But we'll leave the grading form and the feedback form open for a week. So don't feel pressured to do it, you know, straight away. That's one of the reasons we're recording as well, so that those who are not here can have access, and if they want to grade, they can do so. If you are from the maternity services, specifically, you know, focusing on diabetes, we ask you not to grade, just so it's independently, the evidence is independently, objectively graded and assessed. So I will give 1 more minute before we move on to outcome 1C. Okay, it's gone 11:14. So I will call on Eleanor to move on to presenting the evidence against outcome 1C.
So in terms of governance guidelines, these kind of things, there are some very specifically laid out requirements. The main document is from NICE, the guideline for diabetes and pregnancy, and this states things like, you know, women have a review of their blood glucose every 2 weeks. This is also about seeing them early, the scan pathways, and we're fully compliant with all of those aspects. Saving Babies' Lives version 3, I mentioned at the beginning, and this is looking at specific areas where we think we can improve pregnancy outcomes. And diabetes has been nominated for this for the first time. There's element 6. I have a role for this. I'm the Midlands Wide Obstetric lead for this. And we are in a good place. We had a grading meeting for this on last week. And we also have a full day away day on Thursday this week with our wider team in just finalising the clinics the new clinics that we're going to start. So our clinics are going to be separated, and we're going to have some new clinics for women with type 1 and type 2 diabetes, which are going to be separate from the clinics with the women with gestational diabetes. One of the early slides I showed you was the data we submit for the National Pregnancy and Diabetes Audit, and submission for last year's data is closing next week, so that's something we're fully compliant with. And this year they're going to start an additional audit, which is for women with gestational diabetes. We haven't seen the exact requirements for that yet, but that will be coming. The other thing is if we have any late referrals, or we feel there's any potential misses, or if there is a problem within our service about women not being seen or women not being followed up, a DATEX will be completed. We have had, not in recent times, but a few years ago, there was a woman that presented with diabetic ketoacidosis, which is a rare and very dangerous complication of pregnancy. And it was thought that this was escalated. We did a root cause analysis, and it was thought that there was potential to diagnose earlier than we had. So there was a lot of education and actions based on that. And I think we've now got our service in a really different place. So when women present to our maternity admissions unit, there's a lot more knowledge now about screening these women for diabetic ketoacidosis. There's been changes in our guidelines, and there are things like flow charts to support clinicians who are maybe not experts in diabetes, but to support them in diagnosis and in early management when women are admitted unwell. And that has been working really well. We also have very collaborative working, because this service is big, and it's got, there are 3 different areas where it's funded through. So there's the maternity, then there's the diabetes, and then there's the dietetics. And there's been some really collaborative working, not just clinically, but the non-clinical managers have also worked collaboratively on things like business cases on how we provide for the expanding service. We have quarterly morbidity and mortality meetings where, mortality is incredibly rare. We had one loss last year of a baby, and the baby died because the baby unfortunately had multiple abnormalities. But we also talk about times when we think things could have gone better. We talk a lot about our processes during this meeting. Are we happy that, we have the resource to review the blood glucose, and are we capturing our activity to ensure that we can have successful business cases? We have those wider conversations at this time as well. And sometimes we want to highlight things when things have gone really well. I feel that I'm fortunate from the obstetric side in the fact that I see the outcomes. I deliver the babies, I see that, whereas my colleagues in diabetes see that less frequently. So we're very keen to share the pregnancy outcomes with them. I've talked quite a lot about the Getting In Early project, where we're really trying to see women with type 2 diabetes early. And there's also an ongoing study that we've got where we're looking at babies born to mothers with diabetes who are admitted to the neonatal unit, to see if we can find any themes where we could maybe do some more targeted interventions during pregnancy. We're very conscious that this is quite a specialist area, particularly with the emerging technology. And when these women come in either for an acute admission or during labour, we need to support the wider maternity staff who are looking after them in supporting them with their diabetes management. So we have a very detailed guidance which breaks down the different forms of management and the different scenarios and the kind of care pathway that woman needs. So say, for instance, This group of women are at higher chance of delivering early. One of the key interventions is to give 2 steroid injections, because we know that this really helps with the ventilation or the breathing requirements for the preterm babies. Giving large doses of steroids has a very significant impact on blood glucose control. So we need to control the blood glucose in a different way. But that's different for women who are taking metformin. It's different for women who are having multiple daily injections of insulin. It's different for women who are using insulin pumps. It's different for women using hybrid closed loop. So we give some really specific, specialized guidance to each group so that these women are safe. It doesn't mean that one of the specialist team has to be present. Of course, we're available to be called at any time for advice, but we're trying to support it to make it safer for all the women, no matter what day, no matter what time they come into the service. There's also a mandatory training day that all staff attend, and we now have a spot to do a formal education session. Tina delivered one of these last week, and it's at these kind of things where we highlight, if you see a woman with diabetes, refer her to us immediately, even though that's, to be honest, very well done by our community midwives. But we talk about some of the wider issues and troubleshooting. So we are very conscious that our women could come to the service at any time, and we're supporting the wider maternity staff to look after them safely. To you, Marion.
Thank you, Eleanor. Another comprehensive evidence been presented. Can you hear me?
Yes.
Oh, thank you. So another opportunity for us to grade the evidence against outcome 1C using the table on the screen. Does the evidence show underdeveloped, developing, achieving, or excelling activity? You have a range of between 0 and 3 to do that. If you have any questions, any comments, if you want to raise your hand or pop them in the chat, I've been trying to keep an eye out on that. Oh, I can see Tina's.
Yeah, I just wanted to sort of pick out as well that for me as a clinician, and there are clinicians on this meeting, is that the free from harm has 2 different strands. It's got the strands of protecting the women once they're in our service, and also the training that we give to our staff in order to protect the women within our service. And I think that we're fully aware as a team of how important it is to engage those non-attenders to the service, because they're the ones that we know are more at risk, that are more at risk of being at harm. And we have very good procedures in place where we can follow up on more vulnerable women more closely to make sure we can get them to engage where possible and to try and keep them free from harm. And I think that's possibly an element that isn't considered by non-clinicians about the people that struggle to attend appointments or find the multitude of appointments differently. The mandatory training is taught every year by the diabetes team, and it changes year on year depending on what the particular focus is. And this time the saving babies' lives is so important because of the poor outcomes for women with type 1 and type 2 diabetes, particularly for the babies. And from a national guidance point of view, all our women do have a documented 2-week review. That happens, but that's not just face-to-face, it's virtually, and it can be by telephone as well. So we do find it important that we have the ability to engage women every 2 weeks, and that can be from a specialist midwife, or it can be a dietitian or a nurse, or one of the consultants in the many telephone clinics that we have. And as you can imagine, that's quite a lot of commitment for women to come every 2 weeks or to be seen every 2 weeks. So that's why the services change, because we want to keep these women free from harm once they're with us. I hope that explains my clinical point of view a bit clearer. And if anybody wants to ask any questions, then yeah, please do.
Any questions for Helena or Tina, or both of them? You can pop them in the chat, or you can also ask. here and now. And I'm trying to keep an eye on the chat and see if anybody's hands are raised. I can't see any. So if you please grade the evidence using the table on the screen, you have a range of 0 to 3 based on what you think the evidence presented is showing. Is it showing underdeveloped, developing, achieving, or excelling activity? But a range of 1, 0, 1, 2, or 3 for outcome 1C. And you've got a free text box as well to post maybe questions or comments or make suggestions on areas of improvement or actions that can be taken. And if you hold on there and not click on next just yet. So I'll give 1 more minute for that. Hope I'm not missing any hands or any in the chat. And we'll leave the grading and feedback form open for another week. We'll close it on the 31st of January. We're recording this session, so we'll download the recording, send it to everyone invited. Those who are not here who may want to participate in grading the evidence can listen to it and submit their responses through the link that will be given to them. And then we'll collate the scores, but I'll talk about what the next steps will be after all. So it's gone 11:27. So Helena, over to you again for the last segment of this presentation, outcome 1D.
So we have some patient feedback that was gathered in October and November of last year. It was an interview conducted by somebody who doesn't work within the service and is not a clinician, and was specifically recruited to do this kind of work with other areas of maternity as well, because we very much recognise that we need to know what women think, and their voices are by far the most important. You know, there's no point us squirreling away if actually we're not achieving what they need from us. So 32 women were interviewed and asked a total of 17 questions. We have the clinics at both Leicester Royal Infirmary and Leicester General Hospital. And 37% were pregnant with their first baby, 63% were pregnant with their second or subsequent. The women that were interviewed all had pre-pregnancy diabetes, so they were in that very high risk group, the women with type 1 and type 2 diabetes. And there was a roughly even spread, because if I go right back to the beginning, remember these women are quite different. The type 1 diabetes, the women with type 1 diabetes are younger and have had diabetes for longer. The women with type 2 diabetes are older, are more likely to have comorbidities. And also the ethnic diversity is different. The majority of our population with type 1 diabetes is white. The majority of our population with type 2 diabetes are Asian. So I won't read through this. I'll let you have a read through these slides. And this was some of the more open questions. This was some of the comments from the women.
Can I ask Helena, and there might be things I've not checked the chats in the last few seconds, in terms of the positive experiences of the service being reported by patients, is that broken down by the protected characteristics by maybe the demographics. So to know, okay, who is reporting positive responses? Are there any that are not reporting what the experience of the services or any negative experience?
Things like their ethnicity was not recorded.
Right.
This is the group as a whole.
Because I think it will help, you know, if it's broken down to be able to maybe target groups who maybe reporting positive experience and those reporting at all.
Yeah, I appreciate that. This piece of work was done because although, you know, we have this grading today, I don't know how much you're aware of in maternity, but there is a huge amount of information asked from us by a lot of different people. So say to satisfy the requirements for saving babies' lives, this is what this piece of work was done for. You know, we've also had 2 CQC visits recently. There is an enormous amount of information that is required. And we have to prioritize, you know, what we get really in the form we get it. And I can absolutely appreciate that you'd like to know, does a Caucasian English speaking woman feel differently about the service compared to somebody who doesn't have English as a first language and maybe needs an interpreter? I absolutely understand that you'd like to know that, but there just hasn't been the time to get that in addition to all the other requirements from the service.
Okay, thank you. So it is available, it's just obviously it's not part of the evidence assembled, is what you're saying.
No, it's not available. It would have to be an additional piece of work. When we get feedback, we haven't broken it down to ethnicity. No, it's not available.
And not just ethnicity, you know, it might be the other demographics as well, but thank you. Just trying to look at the charts. Are there any comments, any questions?
The thing
or
we
if any to raise.
we're pleased about here was that, as I said before, we view pregnancy as a real opportunity to give everybody access to the latest technology, and everybody that had technology felt supported with it. And you know, half of these women with type 2 diabetes will have been using it for the very first time. So we were pleased to know that they were supported with that. And these were the areas for improvement. Our clinics are very big. There are more than between 40 and 45 women attending in an afternoon. And we know that women wait. And when we start our new specific clinics in March, we're hoping that this will be improved for all women. And that's the last of the feedback slide.
Thank you, Eleanor. Thank you again. And thank you for all the work you've put in, all the effort, knowing how busy you are. It is much appreciated. And, you know, you've mentioned other asks and things that you've had to prioritize as well. And this, you know, the EDS is about where can we make improvements? Not necessarily that, oh, everything's got to be there and showing excelling activity. And even when it's showing excelling activity, it's about sustaining that as well. I saw a question earlier in the chat.
Come across our real commitment to identifying women. You know, I hope that has come across, because that is the absolute cornerstone of our service. We recognize that women have different needs, and the whole team is committed to, you know, addressing those needs and also giving them in a way that the women find most acceptable.
I saw a question in the chat earlier. It's gone. I'm trying to scroll up on that. Okay, I can see Nafisa. I'm sorry, I'm trying to keep an eye on the chat and also see who's anyone raising their hand. Is that for your question? Is that for?
Yeah, I just wanted to say, yeah, thank you. I just wanted to say it's clear that there is a real commitment, and I don't think anyone would question that. There's a lot of work being done. It's just like how Dalver put in the chat as well. My question is in regards to, like you said, obviously there was the survey done, and it's great to see such positive feedback. But the worry is that the feedback is very limited to, and I appreciate that it's very difficult sometimes to get this information, but how do you really know you're reaching everybody, like all demographics, all that should be represented, if the feedback hasn't been taking that into account, if that makes sense. So that's just the question I have, because obviously we do tend to look to ensure that all voices are heard, including underrepresented, even if it's as small as a whisper. We try to ensure everyone is equally taken into account, and that's just the question that we would have. I'm sure you'd be able to answer that. Thank you.
No, I appreciate that. If I could show you that feedback came from people with different protected characteristics, it would be much more reassuring. I think the thing is the amount of things we've been required to deliver over the last 6 months, it is quite difficult to put over exactly how much work that takes. And I think also there comes the point where you think, what do you want us to be doing? Because we do have an enormous clinical service to deliver. So every sort of ask for data and things, and I absolutely recognize the importance of it, but that's then more time away from the service. And because of this new element for diabetes and saving babies' lives, a lot of work has had to go in for that. And that was released in June last year and has to be fully implemented by March. So they've overlapped in very busy periods, and 2 CQC visits with very specific actions between that time. So it's not that I absolutely appreciate that you'd like a little bit more from the different groups, but we just haven't got that piece of work. That was just, that is too far for us at the moment.
Yeah, of course. It's just something to consider for the future. I appreciate there's a lot of work that's been done, and sometimes time can be a limit, can't it? We wish we could do more, but just for something for consideration, because obviously it's like you're doing all this work, and obviously at the end of it you want to ensure that it's going the right way. So sometimes if you could have that evidence at a certain point, you can be like, well, yeah, everyone, we've filled the survey in, or we've spoke to women who may not have English as a first language, and it is also feeding back down that way, if that makes sense.
Absolutely.
Thank you, Nafisa. Dalva asked, am I able to access the survey question? And I'm presuming that's to do with the evidence presented against 1G. She's also asked, okay, I think it's the same question. What are the demographics breakdown of the people who complete the survey, please? I think that the protected characteristics would have supported to ensure we got a voice from different demographics, e.g., we know those from ethnic groups are less likely to come forward, provide feedback. So it is important we make a conscious effort to ensure they have a voice in opportunities such as this. So I think it's just really echoing the point that we've made and what you responded to, Eleanor. Kathy, I can see your hand is up. I was just about to read what you put in the chat. So do you want, is it a comment? Is it a question you have
it's
for
a comment
Eleanor?
just on although we don't have the stats on who was asked, but Barbara, when she came to ask the patients the questions for the questionnaire, she did make a point of asking the interpreters that sit at the general clinic if they would interpret. So I know she did ask for some of the ladies for feedback via the interpreters, which is Mamta and Nisha, who sit at the clinic, but what percentage that was, I don't know. But she did. She didn't just ask women who speak English.
Thank you, Kathy. Fran, is that for a question, or is it that you've done your grading?
No, it's finally for a question.
Oh, okay.
Helen, you just showcased what an amazing amount of work you and your service and the team who are on today do, because it is are huge, but it is a fantastic service, and you should be really, really proud of everything you've done. And I'm just thinking, what would we do without you? We need a Helena. I'm just wondering, Dalva, you've just come into post. This to me represents a really good opportunity for you to pick up some of that work, because Helena and Kathy and Tina, who are on the call, are working there to improve their service on the front line, the clinical service, but they need this feedback. You're absolutely right. Could you work with Nafisa and some of our patients to gather this data to help them?
Happy to, Fran. I think I'm trying to get a meeting with Nafisa, I believe. But yeah, I'm happy to. I don't know. I mean, I can talk offline with Tina and Helena and just see how best to get involved. That'd be great.
Yeah, I just think you're perfectly placed to do this. And obviously, we've talked about language and ethnicity, but there are all these other characteristics that we also need to capture, don't we?
Yeah.
And other vulnerabilities. So I just think that would be fantastic, because then you could inform our diabetes team into making the service even better.
And just to let you know, Helena actually invited Dalva, made her aware of this workshop because she felt it was relevant to the work that she is doing. I can't see any other hands up. I can't see anything more in the chat. I'll give I'll say maybe a couple of minutes if anyone wants to grade now, but don't feel pressured. We plan to leave the grading and feedback form open till the 31st of January, which is next week, Wednesday, after which we will collate the scores and be able to determine what the services domain 1 rating is and inform the service of that way through Helena. So a couple of minutes to use the table on the screen to grade the evidence between the ranges of 0 and 3. 0 being underdeveloped activities, what you think the evidence that has been presented shows. 1 for developing activity, 2 for achieving activity, and 3 for excelling activity. There's also a free text box to comment or make suggestions about improvement areas, but as you can see from Elena's presentation, she's identified, or the service has identified, areas that even they've recognized needs some work or some improvements. I think data will always come up, and it's the different ask, how can you do that? It's we're asking yes for evidence on things, but it's kind of a rhetorical question. A lot of asked, where's the time to do all of that, to be able to respond to that. And I also want to say thank you again, Helena. I really appreciate a lot of work, effort goes into this, and I know how busy you are, because I know how hard it is to get hold of you. You work clinically as well, and you're leading other pieces of work, and nobody can question the commitment to just keep improving things and getting better and better. So thank you again. The QR code, the QR code and the link to the grading form where you can also give feedback is in the chat. We keep putting it in because if people leave and come back or join newly, they won't be able to see what's in the chat previously. So that's why we've been doing it that way. So maybe we'll give 1 more minute. I'm not sure how many people have been grading. I've not seen many hands apart from maybe 1 or 2 who indicated that they've graded. But like I said, we'll leave the form open for 1 week. And then collect the scores afterwards. So it's now 11:45. Anything that you want to maybe say or do to wrap up, maybe in conclusion, Helena? And if anybody then has any questions or any comments just generally about the service. But I mean, what you've presented is, and you know, I enjoy the simplicity of how you've presented it as well, Elena. Well done to that. So even if you're not familiar with what happens in maternity services or diabetes, I think it was educational, at least for me anyway.
So yeah, I think going forward, I absolutely recognise how valuable it would be to have feedback from people with protected characteristics. I hope that I've shown you how aware we are of different women's needs and also the factors that increase the risk of poor pregnancy outcome. I'd say as a team, we're very keen to advocate for our women. So, you know, our women are only 10% of the maternity population, and we've got to recognise that there are women with very different needs as well. So a lot of it we try and do within the service, but some of it we do need to reach out for, which is going into our Getting In Early project. And I think it's been very useful, the conversation with Hannah today, and she's given me a good steer for talking to nurses within the community as they are a key contact for these women. And yeah, we're looking forward to our specific clinics, which will hopefully give a bit more time and space, reduce the waiting time for the women with type 1 and type 2 diabetes. But thank you all for giving me the opportunity to talk about the service this morning. And yeah, I've been really happy to hear all your comments. So thank you for contributing.
Thank you again. So any comments, any questions, any feedback that anyone wants to give now, or maybe use the chats or use the grid in our feedback form? I can't see any hands. Nothing new, I don't think, in the chat, but let me quickly check once more. Okay, they're saying thank you, Helena, to you and the team. You know, you've presented, you know, so plainly, so simply that I'm sure there's a team behind you, you know, as well. But, you know, thank you. I can see a hand. Is that Mina?
Yes, it is. Thank you. Thanks, Miriam. Helena and team, I just wanted to say on behalf of the system, thank you so much for the service you provide and the immense effort that goes into it. I think one thing is really, really clear that's come through, especially from all the elements, this isn't just a trust service. This requires a system approach, and it requires all efforts from all partners in the system, and that includes within the ICB as well, all directorates working together, as well as all our external partners. So I think this isn't a service that, you know, Helena has to run with. I think it's important to note that when we do this grading, it affects all of us. So the grade that we give, it's something which is reflective of us as a system as well. Thank you.
Thank you, Mina. Have I missed any other hands, Pooja? Can't see any. Okay, so in that case, if you pop the last slide on, Pooja, next steps. Okay, slide. Oh, I can see Paul hand. It just popped on, Paul, so I don't know how long you may have been raising your hand. Apologies if I missed that. I think Paul is the chair of one of the patient participation groups. Paul, can you hear me?
Yeah, yes. Can you hear me?
Okay. Yes, we can hear you now.
Well, I just want to say thank you for everybody for organising, but especially Helena for making it all so clear. I had very little knowledge of this before we started, just what I'd read on NHS Cloisters, but you're working very, very hard, and the problems are overwhelming, really, because the societal problems that you're dealing with. But you're working very hard. It's really appreciated. So, yeah, thank you very much.
Thank you, Paul. That's really generous of you. Appreciated.
Any other hands? I'm glad I didn't miss Paul. Just want to check again before I go through what the next steps are. I can't see any other comments in the chat. Okay. Thank you, everyone. Thank you for your time. I know everyone is busy, for taking the time to attend or join this session today. I think a number of colleagues have said it, maybe said it better than I could, whether it's Mina or Kay at the start. You know, this is not just something that we do to tick boxes. It's something that can make a huge difference, and the evidence just shows a lot of work, you know, going on just to keep improving things and make things better for the local population, particularly you know, pregnant women, to have positive better health outcomes in relation to diabetes particularly. So in terms of the next steps, we've now had obviously all the grading under domain 1 of the quality delivery system done now. So today's session is the final, which is why I crossed it out already. We had the other two last November for virtual ward services and tuberculosis services. So the next step in the process is to collate the scores for each of the 3 clinical services. I've already done it for virtual ward services and the TB services. So they know what their domain 1 rating is, and I'll be doing the same for maternity services in relation to diabetes based on the evidence that Helen has presented today, and your responses to that will be going through the scores, going through the feedback that you've provided. We are extending the grading period for a week. So for those who may be here, or for the benefit of those who've given their apologies, some including this morning because something came up, they really want to be here, but they're not able to, because obviously we're all being pulled in different directions. We've recorded this session. We would download it, send the link out. So for colleagues who may want to listen to it, including those who are here today, and then do the scoring in their own time at their own pace, so that, you know, you don't feel pressure that was got to be done today. But if you can do it by next week, Wednesday at the latest. So the plan will be for us to go in on Thursday, first thing Thursday, to get all the scores and the feedback. And what we did with the other services, all the feedback that we got through the forms, the free textbooks or whatever you type in there, everything was fed back to the clinical lead. So in this case, we'll be sending it to Helena, you know, to have a look at. We'll also be feeding back the domain 1 rating based on the scores. And then after that, now that we've done the upgrading workshops for all the 3 services, and each of the partner organizations, so UHL, LPT, and LLR, ICB, have completed domains 2 and 3 of the quality delivery system. How it works, we need to determine each of those 3 organizations' overall organizational rating. So it wouldn't just be focusing on one, it would be adding up all the scores for domains 1, 2, and 3. And then we'll be informing the LPT, UHL, and LLR ICB what their overall rating is based on the scores. So that will be what we'll be doing next. We've held up doing that because this workshop was, you know, pending. There is a reporting template that needs to be updated or fully populated by each of the 3 clinical services. We've had from TB service and virtual ward service. So we'll be expecting to receive from maternity services, focusing on diabetes. And for that to include improvement actions that have been identified and maybe an action plan in terms of how those improvement actions will be delivered on. Then we move on to governance. So all the grading results that I've talked about from grading from domains 1, 2, and 3, we collate them, we determine what each of the 3 services domain 1 rating is, then also what the overall organizational rating is for UHL, LPT, and the ICB for LLR. We take that through the governance processes or structure. So it'll be different for LPT, for UHL, and for ICB. Then we have to take it to the Health Equity Committee, and most likely that might be March, just because of the timescales. It might be February, it might be March, depending on when the dates are the meetings have been diarised for. Once they've been signed off, we have to publish them, and we have to publish them on each of the 3 organizations' websites. That is a requirement. So NHS England will do the rounds to go to see who's done there and what are the outcomes and what are we be doing about the improvement areas that have been identified. If, for example, CQC comes in as well, they'll ask about EDS, so we can obviously signpost them, or they might actually go on the website because they expect it to be published, and that will be on the UHL, LPT, and ICB for LLR's websites. The key thing with the EDS is improvements. Even if you view the evidence presented today as showing excellent activity, it's about maintaining that, it's about sustaining that. But we all know that in everything we do, there's always room for improvement. So the 3 clinical services that Domain 1 has been applied to are required to deliver on improvements. And it doesn't have to be many things. It could be, for example, maybe on the data or the areas that have already been highlighted. And it will vary for the 3 different services, but there might be some commonalities as well. And it's more or less just translating those results from the grading and feedback that you, as stakeholders, have provided into improvement actions, and having an action plan to help deliver on those. And then periodically, maybe quarterly, report on progress, what's happening with those improvements. So that would be different for the 3 organizations, UHL, LPT, and the ICB, to take you through their governance structures, just for assurance, for oversight that we've not just done this as a tick box, but work is being done, to secure improvements and sustain that. So those are the next steps, and those are things I will be working on in the coming days, weeks, and maybe months. And then after that, we'll be looking at identifying the 3 clinical services that Domain 1 will be applied to for the EDS cycle 24-25. And that work will probably start imminently, but in terms of engaging clinicians and services, that might be around March, April. And we hope that by the end of the year, we would have completed the grading workshops for all of that. So you'll be hearing from us from time to time, and you're welcome to participate in any of those grading sessions to give us your honest view and also feedback as to how we're doing. And I'm glad some of you have been able to do that here today, so that Helena can hear that firsthand. A lot of work goes into delivering a service. It doesn't matter how big or small, but maternity, we know, is a huge, huge service. And
Mine's is frozen too.
Marion, I think you're frozen and we can't hear you. We still can't hear you.
Anybody might want to give Yella now and let me know their at. I don't know whether being or and return at. I'm just trying to. I don't know what happened.
No, I can't see Bina on the call yet. Can't hear you, Marion. I still can't hear you. I don't know if anyone else can. Yeah, we still can't get Marion back, but thank you everyone for attending. The survey will still be open until Wednesday, the 31st of January. And we will be sharing the recording once it's all downloaded so that you can listen back to any of the evidence if needed. Thank you.